Hello, everybody. I was half tempted to say good afternoon, but realized that as this is an international conference, everyone's frame of reference for time of day is going to be slightly different. But we wanted to thank everybody in attendance for joining us today. We're here to discuss a local perspective. We're all employees of the city of Philadelphia here to discuss early intervention opportunities for law enforcement and behavioral health. So there's a growing intersection of this work that's been taking place over a number of years. There's a lot of work for what's been done to this point and the potential for where this can go in the near future. And we want to take this session to be able to spend some time talking with you all. We want to encourage the session to be interactive. Mr. Bent is on standby for the conference to flag any questions that may come up in the chat. So anyone that wants to stop us in the middle of the presentation, please feel free to do so. We really are just trying to take some time to be able to, again, share a local perspective about the work that's being done here in the city of Philadelphia in the midst of ongoing multiple crises related to a global pandemic, the rising surge of gun violence in our community, and the opioid crisis that we're all trying to manage simultaneously here. Part of our panelists, I want to introduce them also that are joining me today. My name is Kurt August. I'm the Deputy Director of Diversion and Deflection and Managing Director's Office of Criminal Justice. With me today, I have Rachel Eisenberg, who's the Director of the Office of Criminal Justice, David Ayers, who's a Criminal Justice Program Manager, and this is going to be a mouthful, in the Behavioral Health Division of the Behavioral Health and Justice Division of the Department of Behavioral Health and Intellectual Disability Services. And we have Staff Inspector Francis Healy, who's a special advisor to Police Commissioner Outlaw locally here for the Philadelphia Police Department as well. And again, thank you all for joining us. Please encourage you to be interactive and help us understand any questions that you have. And we're honored to be here with you today to share our perspective. I'm going to turn it over to my colleague, Rachel, to get us started in the presentation.
Thank you very much, Kurt. And so I just wanted to provide a little local context before we dig into some of the kind of active projects that we're working on locally. As Kurt mentioned, there's a tremendous amount of community health and public safety challenges that we're facing as a jurisdiction, including the rapid rise in gun violence and the opioid epidemic. But in Philadelphia, criminal justice reform has also been kind of underway, and there's been kind of a rise in attention on reducing mass incarceration as we have, had an incredibly high incarceration rate as a jurisdiction for many years. And back in 2015, a collaborative group of agency and community stakeholders came together to design a reform plan that focuses on reducing both admissions and lengths of stay in our local jails. And we came at this effort through a number of different strategies, but with the overall goal of reducing the jail population by 58% in 7 years. And those strategies include reducing the number of people who are incarcerated pre-trial, increasing efficiencies in case processing times, creating alternatives to incarceration for violations of probation, reducing racial and ethnic disparities in the criminal justice system, reducing the number of people in jail with mental illness, increasing cross-system data capacity, and fostering meaningful community engagement in the reform effort. And the efforts that we're going to speak about today kind of touch a number of these strategies, but with a real laser focus on people who are experiencing mental illness or substance use disorder or co-occurrence of those challenges. And so as a result of the justice reform in Philadelphia, we have successfully reduced the number of people incarcerated in our local jails by 42% since 2015, which allowed us to close the House of Corrections, which is one of our oldest and largest jail facilities that was due up for replacement. And also, earlier on in the pandemic, we actually achieved almost a 50% reduction in the number of people in jail due to efforts to, decrease the number of people who are incarcerated during the pandemic. the population has since rebounded back up to 42%. And what I should mention is that this effort was really grounded in not just simply reducing the jail population, but also looking at, the disproportionality of people of color who are incarcerated in our jails, and thinking about ways that our strategies could really, try and combat the drivers of inequity that, persist in our criminal justice system, and particularly for Black and Brown communities. But so while we've seen success in our incarceration reduction overall, racial disparities have actually increased. And so that's something we are at a point now where we have to completely revisit our strategies and make sure that they center racial equity, and not just kind of they're not coming at racial inequity around the edges. So this is a segue into my own slide, but at the earliest points in the reform effort, our attention on reducing racial equity was really at creating opportunities for diversion and deflection away from the criminal justice system for low-level offenses that were known to disproportionately impact people of color. And so two major efforts that we took on were increasing the use of civil penalties for nuisance behavior rather than criminal penalties, and locally we call that the increasing the use of a civil code violation. And we also worked hard to implement a growing pilot program, the Police Assisted Diversion Program, which is adapted from the LEAD model, but looks at diverting at the point of both initial contact with law enforcement individuals for offenses that are really driven by unmet health needs, and in particular substance use disorder. And so this project has rolled out in 3 places in our city, and we are connecting individuals with harm reduction services in the community as an alternative to criminal justice system involvement. And since that time, we've really enhanced the way we are examining these policies to ensure that they advance racial equity. So the first way in which we did that is the Police Assisted Diversion Program actually went through what we're calling a racial equity initiative review. So both examining all outcomes data by race and ethnicity, as well as conducting interviews with program participants and agency representatives who are responsible for the program to really identify opportunities to change programmatic policies to ensure that people of color benefit to the greatest degree possible from the programs. And so there were a number of pretty significant programmatic changes that were made as a result of that initiative review, including the elimination of a criminal history exclusionary criteria, which was a really significant change in the program design. The other thing that we are looking to do as a jurisdiction is really think about racial disparity data from a high level. And so something we'll be doing in the coming year is looking at, we've looked at decision points across the criminal justice system. Last year, we looked at post-charging diversion in collaboration with the district attorney's office, and we're embarking on a process now with the police department to look at racial disparities in arrest rates across the city and identify opportunities by digging deeper into disparities data where we can make kind of policy and practice change in an area of focus. And so that's, an iterative process with both practitioners, community members, and thinking about new, engaging new stakeholders to rethink the way that that some of these disparities persist in our system. And one thing we learned from all of this work, as I mentioned, is that there is really a need to shift upstream, that the point in time when people are coming into contact with law enforcement or criminal justice in general is sometimes it's too late to have the kind of impact we want in terms of prevention. And so we as a jurisdiction have really shifted our attention even earlier in the in individuals' contacts with the city and with the justice system. And so we have really focused our attention on some of the work that my colleagues are going to share about that are really aiming to identify opportunities to divert people into services and away from the criminal justice system earlier. And now I will turn it over to Kurt.
Thank you, Rachel. And before we sort of shift the focus of this presentation to things that we're trying to get off the ground here in the near future and sort of our potential for growth and capacity building, we wanted to take one brief moment to kind of give a current overview of sort of the continuum of response mechanisms that exist here in the city of Philadelphia that are currently operational and we believe are doing really important work in the community every single day. And really, when there's a crisis situation, the first line of it's going to start with the crisis intervention teams, the CIT training. We have over 900 CIT officers that have been trained since 2015. And when calls come into the police, there's a crisis response situation. CIT officers are going to be the first line of defense that's going to get deployed into that situation currently. And they've done a lot of really important work with providing the appropriate response based on their training to get people connected to appropriate services, and again using arrest as sort of the last option when it comes to their point of contact. We also have, as Rachel alluded to, our PAD program, our police assisted diversion program, where we're diverting people at the point of arrest for nonviolent low-level misdemeanor level charges that are generally related to complex unmet health needs. So these are like the possession of purchasing narcotics, retail theft, and prostitution related charges, where we're screening people for their eligibility. We're doing our best to remove as many barriers to eligibility as possible. And again, trying to create that off-ramp of further criminal justice involvement and initiate a warm handoff from the point of arrest to targeted harm reduction services that are based on short and long-term community supports. And we're doing that all throughout East Police Division and sort of our Kensington, Harrogate neighborhoods, as well as 2 other police districts. And we work with a unit called the Narcotics Strike Force and Citywide Vice across the city for a lot of that work as well. So there's off-ramps that are connected there. We have an outreach co-responder teams that are operational where we embed behavioral health professionals with our East Service detail. And those are more proactive outreach teams that are trying to address quality of life complaints. So for a frame of reference, I would think more of the kind of quality of life concerns that get raised by local residents in community meetings, the sorts of emails that go into district captains and things of that nature. We try and work to utilize these outreach co-responder teams where, again, we embed behavioral health with police officers to try and be proactive, work together in real time, and try and come with health center resolutions to those kind of quality of life complaints in the community. We also have homeless outreach teams, our community wellness engagement unit, and all of that transitions over to more of our mobile crisis teams. We have an alternative response unit that's based out of Fire EMS where we pair paramedics with social workers for non-fatal overdoses. And then we have our crisis response centers. And all of those things align as sort of a continuum of support options that are made available to people in real time when they're in a state of crisis, leading from an exclusive police response to behavioral health responses and all of the infrastructure that's in place where there's sort of a fusion project that works between all of those entities to kind of collaborate and make sure that we're giving people as many options as possible to get connected to appropriate services in real time. Rachel, could you go to the next slide, please? And we have this sort of set up in sort of an incident and event type that corresponds to a lot of this work. So when there's a mental health crisis situation, when that is going to require an involuntary commitment of some sort, that's going to be initiated by our CIT trained officers in the field. Those low-level arrests, we offer those diversion opportunities that are connected to, again, put people into appropriate community-based supports in real time to not be entangled further in the justice system and try and get connected to help both in that moment and long-term going forward. When any arrest gets made where there's underlying mental health issues, we have like an assessment form that gets filled out and folks can get connected to a program where they can have a clinical assessment that's done before they go up for arraignment that is a case processing intervention. So that information is made available to their public defender and it's used in bail arguments at arraignment to, again, proactively flag people with underlying mental health issues to make sure that they're getting connected to appropriate supports. Even if their case is going to move forward in the justice system, we're taking early steps that are connected to that. Those sort of community complaints that come into police departments around quality of life issues, we have that active outreach co-responder team that embeds behavioral health professionals connected to that. And when there's a non-fatal overdose in our community and the person may refuse transport to the ER, we still have an alternative response unit that if the person refuses transport, we still connect them to a paramedic and a social worker that's going to try and get them involved in some other community-based support, get them access to health services that might not involve a visit to the emergency room. Because just because somebody says they don't want to go to the ER right now doesn't mean that they don't want help in any kind of form. So we make sure that we have teams in the field that are able to make sure that that offer to get connected to help and what feels like help for that person in the moment is made available in real time. And then if people call in the 911, obviously expressing suicidal ideations and other forms of mental health crises, we have mobile emergency teams, these mobile crisis teams that are working 24/7, that work directly with the police department. They go out there and they're able to try and de-escalate that situation and get people connected to appropriate services in real time. And they have their own crisis line that's connected with that work too. But they're really hand in hand, sort of a continuum of care. And that's sort of the current state of our operations here in Philadelphia. But I think the reality is, and all the panelists I think here would agree that although we've done a lot of heavy lifting to be able to produce the work that's happened so far, in a lot of ways you could say we've really only scratched the surface of the potential of what this work can be. And I think my colleagues here are going to talk a little bit in more detail here soon about some things that are emerging here in the city of Philadelphia and sort of the potential for where this work can go here in the near future. So we have a number of priorities when it comes to sort of the near future of where this work can go. And that's going to start with kind of our 911 call triage and dispatch infrastructure, where we're embedding behavioral health clinicians in our 911 call center and the work that's being done there. We're establishing co-responder teams outside of the outreach co-responder model. So these are going to be mental health clinicians paired with CIT trained officers that we expect to be going out and responding into 911 calls in real time, supporting patrol officers in the field for calls that, again, are coming in live to 911. We have our crisis system expansion. So the city is going to sort of go and overhaul our existing crisis system. We really think that there's a lot of potential to revamp that. And Dave Ayers is going to talk to you about all of the work that's being done to kind of build out a greater infrastructure to make that system a lot more responsive. And then we also have the capacity for these alternative responder teams. And we'll talk more about how that looks and sort of what the emerging potential is for those alternative response models that are going to involve non-police interventions and kind of the systems that they'll be tied into as well. So I'm happy to turn it over to my colleague, Staff Inspector Healy from the police department to talk to you more about our 911 call triage and dispatch infrastructure.
Sure, thank you. The plan we have in place right now is actually to try to identify those calls that are crisis related and actually direct them to the most appropriate services in the field that we have. We've been debating and going around and around trying to adjust this or to develop this system in light of the current political environment that we have in the city of Philadelphia, namely our unions. So we are trying to work to figure out which jobs, a crisis call coming in, a person screaming coming in, how do you identify that as a CIT related call, a co-responder model call, or something other? So we're in the process of doing that right now. And the mental health clinician that was embedded into our police radios, the function of that individual at this point in time is to help identify, if possible, how we can better identify those calls. Like I said, we want to have the available resources in the field, but we also want to make sure that we're sending the right type of calls. So like I said, a majority of the calls in Philadelphia, like other police departments, require a 2-officer response. So we are struggling with that right now in light of the union requirements and changes and stuff like that. But it's not saying that we can't get there. We just have another hurdle we have to get over. But identifying those calls and then having that sit down with the union type individuals will be helpful. There'll be a bargaining issue involved, that's for certain. But nonetheless, it's something that we will overcome. But that's the plan right now. And then once we have these baskets or rather buckets developed, The role of the embedded clinician in police radio has yet to be fully vetted. But the goal there is to actually have a live, I mean, this is the police department's perspective, is to actually have an individual available in police radio that can actually respond in real time to call takers who are not necessarily in need of immediate police response. But we found out a lot of times many police officers get on scene and really all they're there for is for the relay of information. People need information about the mental health system. They need to throw it to a family member or something along those lines. And that may be a way to avoid officers actually interacting with people that don't necessarily have to be interacted with by police. As we know, a uniform on the street can obviously escalate in and of itself some incidents. So if we can avoid even one or two of those calls from happening, it's a huge win. So as we move forward, identifying the full duties and responsibilities of this individual and then bringing more people on board to serve that function is really where we're trying to go. Like I said, our city is different from other cities, but we've taken the lessons learned from other cities, and we're trying to see how we can merge them here in Philadelphia as quickly as possible, most effectively as possible as well. Back to you.
Do you want me to move on to the next slide, Inspector Healy, which is this one?
Sure. For the clinician, and we're talking about the clinician and CIT officers, the key what we have there is what we're obviously, I mean, it speaks for itself. We're looking to put CIT officers in the same car with mental health clinicians to be able to respond to those calls directly from police radio. But if that's not necessarily the majority of calls, I see from the police department's perspective, again, a huge need for this type of response for the officer already on scene. As you mentioned, one of the earlier slides said we only had 900 some odd officers trained from 2015, but that really undercuts the true number that are out there. We've trained well over 3,000, 3,200. Now there's been attrition, so we have about a little over 2,000 CIT trained officers on the streets of Philadelphia. So those officers are handling jobs on a regular basis and have the additional training in de-escalation. So it's not like we don't have resources in place. But a lot of these encounters actually are protracted matters. So what we'd like to be able to do is have these CIT officers be able to hand off these assignments to individuals that actually aren't running 911 or aren't running by 911, I should say. And that's the co-responder teams. So they'll have the time and the additional resources to actually handle a lot of these protracted matters in a more efficient way than the actual CIT officers will on the street. And actually, in light of the political environment, again, is something we can't forget. We've been defunded. Okay, people want the police department to do more work with less money and less people. Currently, we're down as of this morning 430 officers from 3 years ago. So we need to be able to do more, a lot more, with a lot less officers. So we can resume officers on the street from protracted matters and actually allow them to respond to other crisis-related calls. When a co-responder team can step up, it will be a huge win and actually create a synergy with hopefully, like I said, we need to take the officers out of patrol to do this function, but in return, we may be able to get much more bang for our buck. So the ability is to be able to get out there and get the right people on scene. And that's with the clinician and the CIT officer teams. I think that's where I talked about the patrol support, which is, I think is, like I said, that's what we're talking about when we say the officers in the field will be reaching out and asking for these teams to follow up with them, meet them on scene. I know other departments out there have had direct dispatch from the radio, which is something we're not abandoning that in any way. We're going to look to see how we can do that effectively, but at least in the interim, I do think this is going to be a huge support for the patrol officers and allowing them to actually go back to more assignments. We have an incredibly violent city, regrettably, so these officers are being pulled in a lot of different directions. But I do think that with the number of CIT officers we have out there, we have a great base to start this project and move it forward rather quickly.
And before we turn it over to Dave, I'd like to also just briefly highlight the role of these peer-based follow-up teams that we're going to have in the field as well. So we're going to have sort of folks that are in that peer-based designation. So we certify recovery specialists, certified peer specialists, outreach worker types that are going to be in a civilian vehicle that are going to be able to follow up in real time. So when these co-responder teams are in the field supporting patrol or responding directly to 911 calls, if there's not a situation where the person's going to need, transport to the emergency room or things of that nature, but we still want to connect with the help, we're going to be able to make that warm handoff to a civilian-based team that has lived experience, dealing with mental health crises, substance use issues, working with families, things of that nature. They're going to be able to spend more time with that individual, try and get them connected to the appropriate level of care, and again, offer that follow-up support 28, 48, 70, 24, 48, 72 hours later to make sure that we're staying connected with folks and making that warm handoff to appropriate services. So we really think that's going to be a powerful addition to this model, is to make sure that there's a civilian peer-based team that's able to do all that follow-up and accept warm handoffs from these co-responder teams in real time so that they can resume service and go address the next issue. We want to make sure that this model is responsive as possible. And also quickly, before we go to you, Dave, Staff Inspector Healy, could you talk briefly around the modified CIT training for call takers and dispatchers that we're trying to get underway here in Philadelphia as well? We think that that also is something that has some potential, nationally and internationally, for ways to integrate call takers and dispatchers into the CIT process, more intimately connected to the crisis response system and the work from there. Can you talk about some of the work we're doing there and kind of the potential for that model?
Sure. Separate and apart from this program, Commissioner Outlaw in, I believe, July or August of this past year, came up with the notion that she believed the dispatchers, and actually we all recognize this fact, but she kind of just brought it right to the light, and it fit perfectly with what we were trying to do, is that the dispatchers have an integral role in the de-escalation process. Now, we recognize that when we did CIT back in 2007, we did some basics training for the dispatchers, but it was more of an awareness training. We really didn't include them in the process of de-escalation and how important they are. That has since changed. And I think it fits perfectly with this overall co-responder model, is that we're actually making better resources of our dispatchers. For those that may not be aware, a dispatcher can de-escalate things on both ends of the scale. One is the call takers calling into 911, as well as how they dispatch the assignments to the officers. Like I said, we all have certain jobs to do, and a lot of times we're just listening for what we need to hear. And a lot of times that can escalate individuals who want to be heard. People call 911 to get help, but a lot of times, more importantly, they want to be heard rather than talked to. And so we've recognized this fact, and as well as the role that the dispatchers have in how they can dispatch jobs. I mean, if they're in a heightened state when they dispatch a job to an officer, you can be rest assured that officer is going there in a heightened state. So what we've done is we've taken the 40-hour CIT class that we currently do. Our CIT coordinator has modified that class with the assistance of DBH and intellectual disabilities. And what we've created is an 8-hour block specifically designed for the dispatchers. Now, number one, this gives the dispatchers the respect and courtesy they deserve, which in most police agencies across the country, this isn't just ours, they're like the lowest peg. And in reality, they're probably one of the most important, just like the police officers themselves. Police officers and dispatchers are much more important than the rest of the command staff, quite frankly. So the issue is making sure we gave them the courtesy and respect they deserve, but giving them that enlightenment. We're not really teaching them to do anything different in their job, but just how to interact with the individuals on the front end with the call takers, as well as how they dispatch the assignments, can make a world of difference. Now, as part of that program, the commissioner also requested that we have a call taker script. I know a lot of other jurisdictions have such scripts, but we've never had one. So what we have now is a mental health call script for all call takers in the Philadelphia Police Radio. When the calls come in, there are certain questions that are asked of all call takers. Now, this is a work in progress, but nonetheless, like, some people can get annoyed. You're calling about, your tires being flattened, and somebody's asking you about mental health issues. So we are constantly tweaking that as we go along with the input from the dispatchers themselves. But what we found is that this script, in addition with the additional training that we're giving to the dispatchers now, we are in fact sending many more calls to our CIT calls officers directly into the field. In the past, that necessarily wasn't happening at the volume it is now. So that is a huge win in and of itself. The combination of the CIT, modified CIT training for dispatchers, and the mental health script, and that script was developed in collaboration with, like I said, our partners, the Department of Behavioral Health and Intellectual Disabilities, was integral in developing that. But like I said, we are giving the call takers the respect that they deserve, and acknowledging their comments and criticism. So we're tweaking it, making it a little briefer, but nonetheless, it's still very, very effective. So I was really surprised how effective it really is. Kurt?
Thank you, Fran. And Rachel, would you mind taking us, I think, 2 slides ahead here? Yeah, there we are. And Dave, before we go into your sort of general presentation, I want to flag 2 questions that are going to be related to your presentation that I'm hoping you can touch on when we come. We have a question from Rachel. Can you say more about the mobile crisis teams that respond to 911 calls related to suicidal ideation? Are these teams co-responder teams, or who are the staff working on these teams? Are these teams first responders or secondary responders? And are they accessible via 911, but also through their own crisis line? And then additionally, we had a question that, again, is just asking for some more information on those alternative response teams and models. So I think folks are hoping that you'll be able to touch on that in some more detail as well. And then we have another general question from Talib that I'm going to ask that we wait until the end of Dave's presentation, and then all of us will take a shot at trying to answer that question when it comes up. Thanks, Dave.
Sure. I think what's really important to emphasize, and what all of our panelists have done to this date, is there's been a lot of work happening over quite a bit of time that's been foundational to what we're attempting to do now. While we're trying to do some things that are newer to Philadelphia, everything is based on the work that's gone before. So one of the particularly important things to recognize is if that we're attempting to identify calls to 911 that have behavioral health components, and then to understand what those needs are and have that be a foundation to dispatching the appropriate response based on the needs identified in the call. We need to have a broader system that's able to take those offloads and to make sure that we're serving the Philadelphians with behavioral health challenges as best as possible. So a concurrent and equally important part of this overall work for the city is to look at our overall crisis system and to try to identify areas that we can build more on, ways that we make sure that we're interfacing, or as Kurt put it, have it be a fusion of the new things that we're trying to bring on with what already exists. So we have a Philadelphia crisis line, and I'll sort of talk about this and in answer to Rachel's question in the chat as well. The crisis line can be accessed in 2 ways. One, directly from the community, where somebody can call in for assistance there. And there's also some offloads from the police radio room where there's indications of suicidality in that caller. So, and the teams that are dispatched to respond in the field to that, there may be other sort of triaging work that happens at the crisis line level, where the individual working with the caller is trying to get more to the core of what it is the caller needs, and when possible to engage in de-escalation and support, but up to and including dispatch of a mobile team. So it's not necessarily a one-to-one automatic dispatch of a mobile team, but there is a process that happens at the crisis line where the operator there will interface with the caller to discern when a field response is actually needed. And so as we work on the co-responder 911 triage component of this, one of the pieces that is part of our developmental process is to figure out how to handle additional offloads from 911 through the crisis line to mobile team responses. So that's something that's part of the matrix of what our department is engaged in as we sort of look at the full 360 that's needed, and really building a robust continuum of responses so that we're able to identify calls, identify callers' needs, and then make sure we're able to line up the right response that matches what those needs are. I mean, that's our department's bottom line, is to serve Philadelphians with behavioral health challenges, to do it in the best and most direct and safest way, and when possible, to assist in diverting away from the justice system. And when that's not possible, to partner with our other city agencies to make sure that we're able to provide opportunities for identification and linkage to services and supports in as close to real time as possible, to make sure that somebody's needs are being met no matter what their justice journey will end up looking like. And then also, as part of the broader picture, there's the incoming implementation of a 911 or a 988, excuse me, direct dial line, which will basically, that's going to be a nationwide initiative. I believe all jurisdictions have until July of 2022 to have something in place to enable that sort of direct call in, so that individuals can begin to realize that 911 is not the only option, that if there's issues that do not require a police intervention, but they have 911 that can be there to hook up to behavioral health intervention. And then, of course, if somebody does call 911, the work that we're doing now is to build that caller identification and appropriate offloading where the opportunity presents itself, so that individuals, if they call in either number, we're still going to be able to direct them to what they need. So that's sort of the underpinning of all of our planning, is to weave this rather complex tapestry together into something that's going to serve the needs of Philadelphians, that's going to work with our other partners where we can assist them wherever needed, and that ultimately we can move to a system that's most responsive to our city. So as part of that continuum of response, if you remember back to the earlier slide where there were all the sort of buckets of engagement, going all the way from police engagement all the way, yeah, thank you, Rachel, for pulling that back up, all the way to alternatives to policing. And again, all of those play a role in the continuum of response. So one of the pieces of work that is brand new that we just recently received through our third allocation from the MacArthur Safety and Justice Challenge is to develop alternative response teams that would be employed when there are calls into 911 that are discerned not to need police response, and there can be an offload to the behavioral health system, and then we can have a team that's a behavioral health only response responding to those situations. So Rachel, if you could put that ART slide back up. Thank you. So we've received some pilot funding from the foundation to begin looking at how we can bolster our existing mobile crisis response team to have more capacity to respond to calls into 911 that have behavioral health components that are most appropriately handled by the behavioral health system. So this is early days. We just, within the last month and a half, received notification from the foundation. So we're actively involved in planning for this component as part of our overall crisis response system analysis, and to see how this can plug in and sort of augment the work that we were already hoping to do. We're very pleased that the foundation has chosen to fund this addition to our pilot that's going to give us greater and more expansive response to crisis needs. One of the other pieces of the alternative responder team, what we're looking at is to have an EMS type involvement along with a peer specialist role. So you can have a team that's able to respond to the variety of needs, whether they be medical, behavioral health, or somebody with lived experience, which I think it's really no news to anybody on this conference, how important lived experience is when we're dealing with, very complex and multi-challenge matrix of issues that people are facing. Somebody with lived experience is able to assist, to recognize, and to sort of drill into what it's like to actually go through some of the things that we're, people in crisis are experiencing, and that can go such a long way where other things don't quite hit the mark totally. So this is something we're all also building into this alternative mobile crisis response, is to have that peer specialist role. And then, of course, everything that we're doing, we don't want to bring up anything that's a standalone, that's not connected to everything else. So in the pilot phase of building up to this team being operationalized, is to make sure that it's connected to everything else in the broader crisis infrastructure. So we're needing to take a careful and planful approach, and also understanding the immediacy of the need. So it's a constant balancing act that our department and all of our city partners are constantly, weighing and measuring. How can we move things ahead? But we need to do it in the right way. You don't want to take one step forward and five back. So you want to balance the immediacy of the need with doing it the right way. And we're doing the best that we can by building the alternative response team as part of our greater crisis response look. We're able to do both of those things. We're taking the planful big picture approach, well identifying a specific need that's going to fill part of that continuum in that earlier slide.
Thank you for that, Dave. And I want to make sure we leave some time here to address Talid's question, because we have a hard stop here at 12:50. I also want to make a brief announcement before we go on around the idea that there's a chat section for each session involved in the conference. So if you utilize the WOVA app or have it on your desktop, you can ask questions for any of the panelists even after the session expires for the life of the conference. We'll be able to see that, get a response back to you over time. So we laid a lot of information out here. There's more to go. But if you had a question that you weren't able to ask or weren't comfortable with bringing up live in the conference, please put it in the chat through WOVA, and one of the panelists will be able to get back to you in a short period of time. So Dave, I'm wondering if we can stop this slide and go to Talid's question because of what we have, and I think it's a pointed question that I think we should try and address. The question is, why have co-responder teams versus just sending a behavioral health specialist? Why are police needed to respond to a behavioral health crisis when there are specialists trained to de-escalate behavioral health crisis in safe and effective ways?
That's a great question. So I can attempt to start answering that, and then I think Inspector Healy can weigh in as well. One of the things that we're doing in our pilot phase of the co-responder and 911 triage work is realizing that in order to send the right resources into the field, we need to understand what's going on with the caller, what's precipitating the call, the crisis call to 911, and trying to discern where there is a purely public safety concern that requires a police only response, or where there might be something more in the middle ground where there's something that involves a police response, but also requires a behavioral health response to co-respond, so that once the public safety aspects of a given call situation are determined, the officer could step back and make sure that the clinician is able to set forward and do what they do in terms of engaging with the individual and family members and whoever else might be on scene to de-escalate, to support, to link to resources. So again, it's a balancing of public safety and behavioral health response. And on the other end of that continuum would be a purely behavioral health response, which would be something like the alternative response mobile team response, where there wouldn't need to be an officer there. So really, it's trying to set up an understanding of the kinds of calls that are coming in, and match all of those types of need with the right response. Some of which will be just a behavioral health response, some of which would be a co-response, some of which would be a police-only response.
If I could just jump in there as well, I fully support what Dave just mentioned. The issue of the team is making sure that the clinician can work in a safe environment. And really, like I said, the ebb and flow between the police officer, and like I said, these are not just average police officers. They are CIT trained officers that are volunteered for the program. But I think it's also important to note, before we put these folks in the field, we actually intend to do a lot of role play training with them, and we're creating a lot of role plays for them to interact as a team. So as where they know when to step up, when one can step back. And the goal here is to get the individual the safety or the help they need in the most safest environment possible for all people present, including the mental health clinician, the individual in crisis, as well as the police officer. So working out with the training we're developing right now, we'll have quite a few scenario analyses, whereas we're actually using our reality-based training folks, the instructors in our reality-based training, to develop these scenarios. And the scenarios will go from kind of like a mild encounter to a more serious encounter, so as that these individuals will be able to interact in advance and learn how to work together prior to ever hitting the street. That way there they can practice and learn as a team in a very, very safe environment, like I said, at the training academy. But once they hit the street, they'll be able to actually interact and be able to step forward, step back, as needed to make sure the individual in crisis gets the best services that they possibly can get.
Rachel, is there anything you want to add to that?
No, I mean, unless there are other questions, I might be able to do this last slide in the last 2 minutes, or we can take more questions if anybody has them.
I don't think at this time, Rachel. Why don't you try and close us out here with this slide?
Okay, great. And so I think I started off this presentation really talking about how we have grounded our criminal justice reform work in trying to reduce racial inequities across the justice system. And we've really carried the learnings from that effort forward into our planning processes for the 911 triage and co-responder work. And I just wanted to highlight a couple of ways that we've done that. We, have community advisors on all of our oversight team, as well as on our various subcommittees. We've actually, are developing a racial equity and community engagement strategy specific for this work that is kind of really focused on getting community feedback on both policy development as well as experiences with the 911 and co-responder systems, and really doing kind of more grassroots engagement in areas where we're piloting aspects of this work. So it's kind of really creating an intentional feedback loop with a variety of community stakeholders, not only established community advisors that we have working with us, but also just, people who are experiencing the systems that we're trying to change. And then also, being very intentional about how we track performance and use data to drive both resource and policy decisions. And so, we are currently building a data infrastructure that brings in data from multiple sources, both the law enforcement and behavioral health systems, and making sure that we're tracking all of our activity by how it's impacting communities of color, how we're putting resources, how we're allocating the resources we as a city have to support in particular communities of color with these alternatives to criminal justice involvement. And so we've just kind of really, from the learning that we've done since 2015, are really trying to be intentional about how we set up an ongoing collaborative infrastructure such that we can kind of bring principles of racial equity into every aspect that we're working on.
Thank you for that, Rachel. Thank you to all the attendees that attended this session. We hope that this information was helpful. We are honored to be able to share our perspective with you. Hope you enjoy the rest of the conference, and please feel free to follow up with us with any questions in the WOVA chat, and we'll try and get back to you. But sincerely appreciate everyone's time. Enjoy the rest of the conference and the rest of your day.
Thank you all.
Thanks, Kurt. Appreciate it.